So yes, I'm Hazel and I'm from the Christie, and the talk is about NHS England's proton service and the Christie perspective. So really, I just thought I'd show you my photo album. It's just after lunch, you don't want anything too highbrow, so a few photos it is. So, what am I going to talk to you about? I'm going to give you a bit of background, a little bit about NHS England's service, and then a lot about the Christie, because obviously that's where I'm from. So the background, what is it all about, these protons? So hopefully most of you in the audience know, if you dig back to the back of your mind, those physics lectures, that the proton is 1,835 times heavier than an electron, so a very, very heavy particle. It's positively charged, and I'm pleased to say it was discovered in Manchester by Ernest Rutherford, so we like to say protons are coming home to Manchester. And it's also a very stable particle, and it also has a relative biological effectiveness of 1.1, which some people could speak for hours about the RBE, but I'll just leave it at it's 1.1. Okay, so us of those that work in protons, we like to say that no presentation is complete unless you have a Bragg peak. So here is the Bragg peak. So again, what is it all about protons? Oh, sorry. The Bragg peak was trying to escape. So, though we can see the Bragg peak and the protons has the sharp fall off and dose, and then you can see conventional radiotherapy, electrons and photons or X-rays that have the gradient fall off. So it's that Bragg peak, that sharp dose gradient that we exploit in proton therapy. So therefore, what sort of indications might we use protons for? What's the rationale? Really, there's two main reasons we use protons. The first one, which usually springs to mind, is to reduce morbidity, is to reduce late effects. By exploiting that sharp dose gradient, we can potentially irradiate less healthy tissue. So that means in young people and paediatrics, we can hopefully reduce the late effects. And I'm sure most of you in the audience are aware now, it's not just about curing cancer, it's about living with and beyond. So we're trying to improve that beyond period, which protons can potentially do. So that's paediatrics and young people. The other main reason we can use protons is to dose escalate, and that's predominantly your adult population. So that's tumours that lie in difficult areas, they lie near critical organs, such as the brainstem, and it's almost impossible to get a tumicidal dose in, even with the fancy technologies we've got today. So when I first started in the proton project, I thought it was all about paediatrics, and actually there is a large adult population as well. And when we're fully ramped up in service, we'll treat about 25% paediatrics, 15% TYA, which is 16 to 25, and the remainder will be adults. So again, no presentations probably complete without seeing some dose distributions. So this is actually a slide from Adam Aikenhead, who's one of our physicists at the Christie, and this is some work he did on prospective planning studies of sarcoma. And you can see the images on the top are conventional photon plans, and then the images on the bottom are various proton plans. DS is double scattering. The others are pencil beam scanning, which is second generation technology. Double scattering is first generation. So the equipment we're getting at the Christie is second generation, which is pencil beam. And you can instantly see the better dose distribution. You can achieve both A, with protons, and B, you can see a better dose distribution with the second generation technology known as pencil beam scanning. Okay, so what about NHS England and their visions for protons and a service in England? So back in 2008, NHS England commissioned proton therapy for English patients overseas. And you can see on the graph that year on year, more and more patients have been going overseas. They've commissioned a few centres, a couple in the US and a couple in Europe, which is great. I'm sure many of you in the audience have come across your own patients that have been sent overseas. They offer a very good clinical service. However, it's not ideal, as you can imagine. These patients have to take months away from home. It's very disruptive. Sometimes patients are not eligible because they've got other comorbidities and they can't fit a transatlantic flight in. Other reasons could be socio-economic. We at the Christie have had a couple of patients whose parents have had criminal convictions and they can't get visas overseas. So we like to say criminals are welcome in Manchester. So at the same time, so 2008 we start sending patients abroad. So at the same time NHS England said actually what we want is we want to have a service in England too. So you can see how long this has been going on for. So quite a few centres put their hat in the ring and said I would like to run the service. And in the end, the Department of Health and NHS England chose the Christie, which is in Manchester, and UCL, which is in London, as a joint bid. And the idea is, it's one service at 2 centres. Each centre will have 3 treatment rooms. We jointly procured the equipment, which was a long, arduous process, but successful without legal challenge. And when we first open, so the Christie will open towards the end of this year, autumn this year, and UCL will open in 2020. And the first thing we'll do is start repatriating those patients from overseas. But the overseas programme will continue. So again, if you're involved in supporting patients that go overseas, that programme will still continue for at least a couple of years until both centres are fully ramped up. Each centre has the capacity to treat up to 750 patients a year. But again, when we open our doors, we won't immediately treat 750 patients. It will be a safe ramp-up period, and we'll introduce different indications. The last one being medulloblastoma or whole CNS, because that's the most complex radiation planning, as it is in the photon service. It will be a centralised referral process, so the process will be exactly the same. What this means is the Christie are developing a referral portal. It's actually at the pilot testing stage at the moment. So if I was a clinician, whether I was at Cornwall or Newcastle, I would input the clinical data electronically into the referral portal and upload all the relevant scans, and then that will get picked up by the relevant centre. So here's a couple of pictures of our partners, UCL in London, and just an acknowledgement to them for the pictures. So the London is a much more complex build. Just building in London itself is very complex. So for those of you that are aware, UCL is just down the road from Euston Station, so you can imagine how busy it is. And they are actually building 30 metres underground, which you can see on this cross-sectional diagram. So very complex. 7 boroughs of London boroughs every time they want to get any equipment delivered. And indeed, they did get some equipment delivered a couple of weeks ago, and I'm pleased to say this is a picture of their cyclotron arriving, and I was invited to the event. I'm very proud and pleased to be invited and part of the event in London. So we work very closely and we have a great partnership. So the Christie, this is me. This is the Christie at night. And I put this shot on, Christie at night, because our staff will be working into the night. I say that with a smile. So here we are. The equipment. So as I said, we did a joint procurement equipment with London. And this is the configuration at the Christie. We'll have 3 treating rooms, 1 cyclotron, and obviously that's the difference between protons and conventional radiotherapy. With a LINAC, each linear accelerator has its own accelerator, and it stands alone. But with proton therapy, in this configuration, we only have one cyclotron and 3 treatment rooms. So that means if the cyclotron goes down, your whole service is down. So this is going to be challenging and new. Fingers crossed it doesn't happen. But at the moment we are working on contingency plans, and at the Christie we're lucky because we're a big radiotherapy provider. We have 14 linear accelerators across 3 sites. So if we need to do backup plans, we've got quite a few linacs to choose from. Now, the eagle-eyed will have noticed that there's a 4th bunker, correct. The 4th bunker is the same size as a treating bunker. However, it's a research room. It doesn't have a full rotating gantry. It just has a nozzle in simple terms. And that room is under the sort of control, as it were, as a research party under Professor Karen Kirkby from Manchester University. So they'll be doing preclinical research in that room, so irradiating Petri dishes and probably talking about RBE a lot. So that's our configuration. So the equipment we went for was Varian. And again, I've seen Varian's got a big stand outside, and many of you will be used to Varian equipment. However, at the Christie, we do have a couple of Varian linacs at one of our satellites, but we're predominantly a different vendor, Electa Linac. So this has been a bit of an uphill challenge. It's getting used to new equipment and a new oncology management system software, ARIA. Whereas our friends in UCL, they are a Varian site. So it's been new for us. Pretty much, you can see from this picture, the nozzle's quite large, but everything else is not too dissimilar from a linear accelerator. One of the other differences, though, which you can just see in the picture, the one to the right, is there is an imaging bay within the treatment room. And what this means is we don't have to go outside to take our treatment verification. So we can take 2-dimensional X-rays in the room, and we can actually do cone beam CT in the room. And this is because when we go outside, we have to wait for the beam because we've only got one cyclotron. So this reduces the amount of time you're leaving the patient in the room. So this is a new working practice for us. And I'm pleased to say we've got cone beam CT as well, because those of you who have dipped your toe into finding out about protons may have come across the knowledge that many proton centres are actually behind our photon technology and still predominantly using 2-dimensional X-rays for verification. Cone beam CT has only really been around the last 18 months. So I showed you UCL cyclotron being delivered. And you might have thought, well, why is it being delivered now if they're not opening until 2020? They're delivering it, they're 30 metres underground, and then they'll build 5 stories above. Whereas the Christie were built, I should get the tent right, above ground, because we sit on bedrock. So we built above ground, and then in simple terms, like you can see on this picture, we left the roof off, and we just carefully lowered the equipment through the roof. So you can see the cyclotron, but the gantries went in the same way. And if we need to take them out in 20 years' time, that's how they'll come out. Interestingly, UCL are near the underground, so they had to do a lot of tests there. And if the fast train, the HS2, comes, that will actually go quite close. So we did quite a lot of engineering work with the railways as well. So this is a close-up of the Manchester cyclotron, which we've named after Emmeline Pankhurst, the famous Mancunian suffragette, and some of our physics team have graffitied, as you can see. And then a bit of an arty shot, really. I did warn you, it's my photo album. So this is a picture of the cyclotron again, which you can clearly see it comes in 2 parts. And then another arty shot of the gantry, of a chap putting the gantry together, or swinging on a rope, whichever you want. And then this was taken maybe a couple of months ago, so you can see the gantry coming to shape. The first 2 gantries now have the full covers on, and they are undergoing commissioning by our physics team. The 3rd gantry will come on a little bit later in the new year, and this is some of my radiographers who are, we can't go in the back now, but they are in the back actually stood underneath the gantry. So the size of the equipment is 3 stories high, that gantry. So luckily the patient can't see that, but when you are allowed round the back, it's absolutely mind-blowing. But now, because obviously the beam line is active, we can't routinely go round the back. And that was a big day for us, a big day at the Christie when we got our first proton beam out the equipment. Lots of smiles and high fives. It's not all about protons though. We do have other bits of equipment which in relative terms felt like we were just shopping for some shoes. So we've also got a dedicated CT scanner, the image to the left there, Siemens, and then we've got a dedicated MR scanner. And that again we found really exciting as a therapy radiographer community to have our own MR scanner. So I'm sure most of you are used to working in partnership with our diagnostic colleagues and maybe having a couple of days a week or a couple of afternoon sessions on an MR scanner. But this is purely for radiotherapy planning. We procured it for radiotherapy planning, and that was what our service specification was. So this has been one of my drivers, that the therapy workforce should be working on this scanner, and we should be working towards designing, in which we are, a competency-based system to work on this scanner. And I'd like to also publicly say a thanks to Newcastle, who've been very supportive, because they have really led the way at having MR in radiotherapy, and we've been up a couple of times to visit them and seen how they've done things. So as I say, a public thank you to them. We have employed a couple of diagnostic radiographers who are absolutely fantastic, and they're working alongside our therapy workforce to upskill them. So it's true collaborative working, which is great. So that was the equipment. Now onto the build. So we were given 125 million from the government for this project. So that includes the equipment, the build, the project work, the staff salaries for the project, the capital side, not the revenue, not the ongoing costs. Okay, so we started off, we knocked an old ward down. It was a single-storey bungalow, which was the old young oncology unit, and you can see that was in 2015 when we knocked that down. And then early in 2016 we started building, and we actually built at first just a big concrete box for the gantries to go in, and that's what you can see here on the image on the right. So you can see there's 3 blue cranes, that's each of the gantries with the blue crane coming out. So you can see we built around that, left the roof off, and then dropped the equipment in, as it were. And then now, this is actually a month or so ago, the whole build. So we built the concrete boxes, and then the front bit, which you can see on this image, is the glass. That's the clinical building, and that's the waiting areas, the clinic rooms, and where the CT and the MR go as well. And now, actually, this area has been further landscaped, so we're not far from a complete finish on that front. Just a bit of snagging. That's all I'm doing at the moment, snagging, bane of my life. So what did we actually build? We built 4 floors. Now, it's not all protons, the same as UCL are building a big haematology suite. We, as a trust, also took advantage of the build. So the L0, the ground floor, the little grey area shaded out, that's the entrance to protons, and I'll show you a picture of that. The remainder of the ground floor will be a new outpatients. All of the first floor is protons, all of the second floor, a little bit of the third, which is just staff change and MDT, and none of the 4th floor, so that's going to be probably a new ward or whatever the trust decides. So, the ground floor. So as I said, we just have a designated entrance into the proton build. So this is not quite finished. As you can see, it needs furniture and bits going in. So what this area is obviously a meet and greet. And then this is, you can just see in the back of the image there, to the right, it's like a glass office. So that's going to have to be some very tidy staff that sit in the glass office. And those staff are support services for patients. So it's deliberately in glass, and there'll be a youth support coordinator, a social worker, play specialist, and it's so the patients can see, oh, the social worker's in, I need a hand with these forms, I'm going to go and see them. So that area is all about patient support, non-clinical in that area. So then we move up to the first floor. And this really is what you're used to. This is your radiotherapy department. So the top bit in the blue is imaging. So that's where our MR and CT, and as I said, dedicated imaging for planning. And each of those scanners has an anaesthetic induction room and piped gases, so we can do patients under anaesthesia. And the red area is like having a little theatres and a ward in the middle of your radiotherapy department. So everything is totally integrated. So we've got a 3-bedded recovery area. So it doesn't matter whether you've gone into CT under anaesthesia or you've gone into one of the gantries, you'll come back straight into the recovery area. And then we've got a 4-bedded, we're calling it a day unit, and that's where your longer stage recovery, which is like you've had day surgery and you go up to the ward. And then obviously we've got a nice reception wait. So this is just showing you one of our waiting areas. So this is the paediatric wait. So we've got designated zones where the patients can wait, and everything looks nice, shiny and new. And this is really just to show you the completeness. This is one of the anaesthetic recovery bays. So we're just bringing the equipment down at the moment, and what we will be doing next is we're going to do some anaesthetic dummy runs. So that's simulating, a various room and pass me the equipment, etc., just to check everything's stocked, and should an emergency situation happen, or hopefully not, but everything is to hand. And then what we'll do next is we do have a paediatric service for photons, is we're going to start scanning the photon patients in the proton build to get used to using the equipment of the anaesthetic areas. What I didn't say is we've already started using the CT scanner for conventional photon work. So again, it's just getting us used to using the area. We're using the scanner, and we've done the same for MR. We've done healthy volunteers, which are the staff, and then we've done patient volunteers, and we're just working with the Children's Hospital to do some paediatric patient volunteers as well. So the aim is we'll have used all areas apart from actually delivering the proton therapy before we go live, so it's not everything new at once. So the second floor, this is split in half, and I've just shown you the front half. So this is just like a mini outpatient. So again, it's fully integrated. We've got all nice new shiny clinic rooms, and again separate paediatric and adult waiting area. And the paediatric is really nice because it opens out onto the courtyard, and this is the courtyard where it's got a little slide and things, soft play mat. Okay, so we've done the build, we've done the equipment. What is the actual clinical service? And this is a very quick run through, but hopefully we'll have time for questions at the end. So, how does it work? So I mentioned about the referral portal, and that will come over to the Christie. And what will first happen is the yellow box is we'll have a site-specific MDT where we'll discuss protons. So it's not a big MDT, a staging MDT. It's not replicating that MDT. That will have already happened at the referring centre. This is a very focused, small MDT that says yes for protons, no for protons, or maybe. And the maybe is you're a base of skull and you need to go for further surgery before we can consider, and then you come back through the loop. Once the yes happens, and I'll come back onto that, each patient will be given a key worker, who to me is probably one of the most important people in the pathway, the glue that brings everything together. The patient will then come to the Christie for what we call an assessment visit. And in that assessment visit, it'll be between 3 and 5 days, and that's where all the planning for the proton therapy will happen. You'll have your CT scan, you'll have an MR scan, you'll have your immobilisation made, you'll meet the consultant, you'll sign the consent form, and depending on your age and the nature of your disease, you may see others. So what I mean by that, if you're 5 years of age, it's likely you'll see the anaesthetist and have an anaesthetic check. If you're head and neck cancer, it's likely you'll see the speech and language and the dietitian. So again, the Proton Centre is in an established oncology centre, so we have all this support network to provide to the patients. So then the patient will go home for between 2 and 3 weeks whilst we do the planning, and then they will come back to us for the treatment. And the fractionation schedules are what you used to in photon therapy, so between 4 and 7 weeks. And again, some patients may be on concurrent treatment as well, and there's no new novel agents, the agents what you used to. And if, again, if they're on concurrent therapies, as I said before, we're in an established oncology centre, so we can deliver those therapies on site if you're 16 and above, and if you're a paediatric, they will be delivered at the Children's Hospital, and all paediatrics is shared care with the Children's Hospital, and we have a very safe, robust relationship with the Children's Hospital. And then, of course, you'll finish your treatment, and then there'll be surveillance either back at the Christie or with the referring centre. So workforce, and this usually, if there's any managers in the audience, often get asked questions about workforce. So in the Northwest at the Christie, what we have done with regard to radiographers is we work closely with our other radiotherapy providers, which are Preston and Clatterbridge, because we didn't want to destabilise the radiotherapy workforce, and we have a great relationship across our Northwest radiotherapy. And we worked with our Liverpool University, and we increased the commissions on that course, and that was back in 2016 on the fast track postgraduate diploma course, and they've graduated this year, so perfect timing to fill the bottom upwards. So this is my work partner, Dr. Ed Smith, in the middle. We work extremely closely together. He's the clinical director for Protons, and this is some of his team of clinical oncologists. Of course, I'm biased, but they are a great team. And I will say it probably more than once as I go on, this is true multidisciplinary working. When I first started in this project, I was the only radiographer, so I had to work along with the lead physicist and the lead clinical oncologist. We had to be able to successfully deliver the project. So the paediatric team, so our clinical director is a paediatric clinical oncologist. So this is paediatric team here, which again I'll mention a couple of these individuals as we go on along, but we've got anaesthesia in the picture, we've got nursing, we've got key workers. So again, it's about everybody pulling together. And I have to say, there's many things I've enjoyed about being in this project, and I will say it's a privileged position, although it sounds a bit corny, but it's true. But I've really enjoyed working with the other disciplines. I've enjoyed pulling together. I've enjoyed learning off their different skill set and seeing how we can work synergistically together. So just to go on a little bit more about the multidisciplinary, this is our paediatric nursing team led up by Sister Jo Roberts, Senior Sister Jo Roberts in the picture. And we've done something else novel and new at the Christie. It's actually for paediatric medical cover, we've employed a paediatric nurse clinician. So there's lots of adult nurse clinicians across the country, but actually paediatric nurse clinicians are a rarer breed. And I have to say, Paul's come with a wealth of experience, 17 years as a nurse clinician working in acute medicine at a local A&E, and before that on intensive care. So I have great sort of faith in him, and I can hopefully give the reassurance to those referring centres who are going to send those children, they will be very well looked after. I said I would come back to the key worker, and I will reiterate again, it is one of the most important functions in the whole pathway. So as I said, at the MDT, as soon as we say yes, you're coming for protons, the patient will be given a designated key worker. And they are a team of either specialist radiographers or specialist nurses. And again, that was deliberately done. They're each in partnership. So, for example, the head and neck and sarcoma key worker, one is a nurse, one is a radiographer, because of that synergistic skill mix. And we found from the Christie, in some of our satellites where the two professions work together, it's worked really well. And I have to say at the moment, it's working really well. They really complement each other. Of course, we can't forget the radiographers, and this is a picture of a mixed team of therapy and diagnostic radiographers. These are our Band 7 superintendent team, and again, of course, I'm biased, but they're absolutely fantastic. And it's been a pleasure for me to start this project as the sole radiographer, and then be involved obviously in recruiting these staff, and then to watch them get enthused about the project and absolutely drive forward with it with the same enthusiasm and dedication that I started with, which is absolutely brilliant. And what again I think is nice, so we've got Lindsay, which is to the far left there, a diagnostic radiographer who came over from the Children's Hospital. I didn't think when I first recruited her, and I gave her a uniform on the first day and didn't think anything about it. And then a couple of weeks later I thought, oh, I wonder if she wanted a different uniform. I wondered if she wanted to be identified as a diagnostic radiographer. So I took her to one side and asked her, and she said, no, I'm part of the team. I want to be in the same uniform. So there they are, the Band 7s, I say, brilliant. Anaesthesia. So again, this is something not new in one respect. As I said, we do have a paediatric service and we do use anaesthesia, and we have a tag team that comes over from the Children's Hospital. What is new, and what I was a big driver for, is the clinical service the Children's Hospital provide is outstanding, it's excellent. But I also wanted some ownership from our own staff and some integration. So what we've done is we've employed Andrew Nevins, which is the picture here, and he's an operating departmental practitioner, and he's taking ownership for that service. And we're also going to rotate one anaesthetist and one theatre practitioner from our own Christie theatres and have a mixed model. So again, this is new, but it's about pulling everybody together for one shared goal. And other support services, again, I've said a couple of times, we're in an established hospital, and it's about providing patients with the right support. So here we can see our play specialist, and then the top right is Claire, who's newly appointed. And I was successful in getting some funding from the Teenage Cancer Trust, and she is a youth support coordinator. Because these families are still coming away from home. They're only going to be in the centre for about an hour a day, all being well. So it's what to do with the rest of the time. So Claire's going to do some outreach work and probably go to our accommodation provider. And it's not just about radiographers in the AHP bracket. I've worked closely with the other AHPs, dietitians, physio, speech and language, OT, and we've made sure that there is designated support amongst this group for all our patients. And then our healthcare assistants or clinical support workers, as they're known, we've got 14 of these. We've not recruited them all. And again, absolutely fantastic team that they will be doing everything, meet and greet, concierge, taking blood, doing dressings, a truly motivated and flexible team led by Kaylee there at the front. And you might think now, we've talked a lot about clinical support services such as physio. Why have you put a picture of physics and engineers in? Well, we can't do anything without this group of people, and they might not all be front-facing, patient-facing individuals. But again, they are an absolutely fantastic team, and often they are the unsung heroes. And a special mention really for Sean Atherton, who's our lead engineer and has worked tirelessly on this project, pushing things forward. And most proton therapy services worldwide, the vendors' engineers just maintain the equipment and sort it out. And again, what we've done, something new at the Christie, is we've got a mixed model in the engineering team as well. And Sean's got his own engineers who've been working alongside Varian, which has been a real success story. So it's thanks to him. And then the picture in the centre is obviously the physics team are at the moment working late nights, commissioning and getting all the protocols ready to be able to treat our first patient. And really this is almost my final slide, it's the penultimate slide. The real most important people in all this is the patient. And I set up a proton patient representative group. These were Christie patients who had been overseas for treatment. And the reason I set it up was I want to try and create a patient-centred service. And by that, I wanted to know what it was like being away from home. What did they require from the accommodation? What do they want from patient information? How do they want to receive that information? So from this, I've met them 3 times, and each time they've absolutely blown me away. When I set up the group, I thought nobody's going to say yes, they're not going to want to come. Then when they said yes, I started to worry, well, they're going to come and they're not going to say anything. And as I said, they absolutely blew me away. I couldn't shut them up. They wanted to tell me everything. I had a mixed group. There was children in the group. There was teenagers, mixed socioeconomic, one whose father was an anaesthetist, one that was unemployed. But absolutely all together in one room wanting to share their experience. So from what they've told me, they told me what type of accommodation they wanted. So we've now signed a contract with a provider that hopefully suits those needs. They wanted an apartment hotel. They wanted flexibility. They wanted twin beds. They wanted a sofa that could be a sofa bed. They've also helped with the patient information, telling me what they wanted. Some actually said, it's all very well, you're giving me all these booklets that look really nice, but can I not just speak to somebody? So that's exactly what we've done. We've built that into our pathway. So when at the MDT and the key worker is named, that key worker is actually going to speak to the patient. Novel, hey? And this is 2 of our paediatric patients who went overseas, and they started off the proceedings for our cyclotron being delivered. And this is actually my final slide, which is all the team who were in on the day for the photograph. Just to say, I'm here obviously today as a representative for the Christie, but this is true team working, and without everybody in that team, it doesn't matter what your profession is, it doesn't matter what your grade is, you all, or they all, have a really important part to play. and they are all pieces of the jigsaw. Thank you.
Thank you.